First, we should make a clear definition of what bias is. And for this purpose, I have two very useful links for you. An article from Cochrane, the Cochrane Help Catalog guideline, and the Catalog of Bias. There it is, bias is defined as, bias may be defined as any systematic error in a study that results in an incorrect estimate of the association between exposure and risk of disease. So you make a measurement and you have at least two groups, the study group and the control group, let us say. And if your measurements between your estimates between the two groups, or more, you may have also more than two groups, of course, between the groups, if there is a systematic error happening because of your study design, that we call bias. And if you look to the catalog of bias, this is very broad, I think. It is very useful. Look here. There is a list of biases. There are tens of biases here. You may click on any one of them and read in detail what it means with examples. This is a beautiful, good, well done website, I believe. But our intention today is limited because of the time, presentation time. It will be limited on selection bias, application bias, or we call it performance bias, measurement bias or detection bias, attrition bias, or loss at follow-up or withdrawal bias. And lastly, publication bias or reporting bias will be mentioned during this particular presentation. These figures are from the Cochrane Help guidebook, and I believe they present the issue very nice. That's why I decided to use this figure. You see here a flow chart of a study, and those who are experienced or have followed the previous presentations of mine, they should be able to recognize right from the first sight that this type of study design is a randomized controlled study, isn't it? You have a target population, you allocate the participants, you select some of your participants, you allocate them into intervention and control groups, two groups here, it might be more than two groups. Then you have an outcome which you measure, you assess the outcome. The intervention group receives medication A, the control group placebo or medication B, and you have an outcome like blood pressure, systolic blood pressure. You measure the systolic blood pressure and you publish your report, you write your report and you make your publication. So at each stage of your study, you will encounter with some different types of biases. And here you see the order where you will come across with the different types of biases. Selection bias right at the beginning, then performance bias, detection, attrition, and finally reporting bias will might happen. The foremost important is the selection bias. Let us look in more detail in this selection bias, what it is. In the selection bias, you have a population, a target population, and from the target, you are trying to select a sample which you will analyze, which you will include in your study. So everybody in the population should have the similar chance, similar probability of being a candidate for you. If it is you do this selection randomly, then you can assure to have a similar probability for everybody. Otherwise, if you select a convenience sample or apply some other sampling methods that might not be random, and there you will encounter bias. You will come across with bias. Then let's go back to this figure again. After selecting your population, you have to allocate them into the two groups, if it is a randomized control study, of course. So how did you do this allocation? Was it also randomly? And more important, or at least similarly important, is it concealed? Was the researcher aware, or the data collector, a scientist aware, which particular patient is going to enter which study group? If I know that this patient will be the control group, in the control group, and I have some empathy with the patient, I might change my opinion and move the patient from the control group to the intervention group. So to prevent this, it is suggested to have a concealed allocation. The groups must be established in a way where the scientists will not be able to interfere. That might be with an envelope, concealed envelope, or some computer-generated methods, or some other methods. Then there will be, of course, in any study, non-respondents. Some participants will not be interested, due to some reasons, to participate in your study. So if those who do not participate are different demographically or clinically, different from those who participate, that might be an issue too. We are supposed at least to compare the demographic features and tell our readers of our scientific work that the respondents and non-respondents were similar regarding age, sex, or some other variables. Selection bias occurs when recruitment processes lead to a sample that systematically differs from the target population in important characteristics. For example, you are studying the effect of cell phone towers on head and neck cancers. In this example, how you would select your participants, you should somehow do it randomly. But if you select based on the cell phone numbers, that would mean you are not be able to include people who do not use cell phones, or you might be biased by selecting participants from a certain company, cellular phone service providers. So it would not be correct, and it would lead to a bias. Another example, primary care, secondary care, or tertiary care, or the community. People seen in these different settings might also be different. If you select your patients from primary care, they will be certainly different than patients in the tertiary care. Even primary care patients, participants, and the population might not be the same. Here, two graphs to compare this. For example, in a tertiary care and community, you have in the community, of course, fairly similar proportions of men and women. But we know that women get more, have more symptoms and consume more health services. So if you run your study in a clinics, in a hospital, in a tertiary care, and then claim that you are representing the whole population, that might not be correct, because in the community, the age or sex or some other distribution of some other variables might be not exactly as similar as it is in the community. So the best is, of course, to run your studies in the community, but that's that's not easy, and that consumes a lot of resources. Therefore, most studies you will observe that they are done in the clinics, in clinical settings. Another issue is this healthy worker effect in the participation. What is this? You see here an example, vinyl chloride industry. People working in the vinyl chloride industry, they measured their mortality rates. And you see that recent employees have a less mortality compared to people who are employed for longer times, 15 years and more. So what would be the reason? First, of course, you will say there is an age difference. Probably those who have worked for 15 years are older, but there might be some other factor, because the company most probably has a health examination at the beginning. So all the entrants into the company, all the factory workers were healthy at the beginning. They were examined. That's why the healthy entrants, they will, the prevalence of the disease, if they are exposed to some risk factors, it will not be evident in the first months or years of the exposure. So it will come later on. Therefore, people who, that's especially important for cohort studies, in the early phases of the study, the prevalence we observe might be misleading. Okay, that much is enough, I think, for selection bias. Let's go over to the performance bias. Here, we are speaking about how we apply the study, how we run the study. After allocation to the intervention and control group, that must be, we said, blind. If possible, we should have blinding of the participant. The participant should not know what kind of intervention or medication he is receiving, she is receiving. Also, preferably, the researcher, scientists should also be blinded. Is it possible? Not always, but whenever possible, we should go for this blinding. So was it single blind, only the patient, or double blind? And what about the placebo versus positive control? Because sometimes we have a positive medication controlled with a placebo, and sometimes a medication controlled with another medication, another intervention. Let me give you the example of acupuncture. If you do acupuncture, you puncture the skin with some needles. And if you have some people in the intervention group and in the control group, there's nothing, they receive no puncture in the skin, that the placebo effect, of course, of the intervention group will be much higher. So you should have some sort of fake acupuncture or mock acupuncture, whereby you will imitate needling the skin. Otherwise, you will have different amounts of placebo observation in the groups. Okay, I hope that was clear for the examples were valid and understandable for the performance bias. Let's go over to the detection bias. Once you have set up your study, you need to collect data. You have to make measurements, and at the level of the measurement, what is important? The device, the method how you measure it, your scale, is it calibrated? Is it measuring correctly? If you are making a laboratory measurement, is the laboratory device calibrated properly? If you are measuring the blood pressure, is your cuff appropriate for the arm of the participant? If you are making a psychometric measurement using a questionnaire, that's pretty similar. Then there also you need the calibration of the device. If you're measuring the instrument, if you're measuring a depression, the scale which is supposed to measure depression should be tested, have been tested before, and valid and reliable. So also at the detection phase, we may face with bias. That is and particularly important also for case control studies, because you remember in the case control studies, we had the cases and controls, and we were tracking back and asking them some questions about their past, about their exposure to some risk factor in the past. So recall, in this case, might be an important issue. Maybe there will be differences between the exposure and the cases and the controls, the patients and the healthy people regarding the exposure. Somebody who has already got lung cancer might have his memories with more occupied with his smoking behavior in the past. So he might be remembering things different than the control group. Okay, a definition of the measurement bias in this slide. Let us read it. Measurement bias occurs when characteristics of measurements systematically lead to differences in the study sample as compared to true characteristics in the target population. So if you have a systematic error in your measurement, as I said, if your scale is not measuring correctly, properly, that's called the measurement bias. And an example here in the slide, your blood pressure. If you use the same blood pressure cuff for all patients, no matter what size the arm is, children have smaller arms, women have small-sized arms, obese people and adult males have larger arms. So you should be careful when making your measurements. How precise it was. Arterial blood pressure, as I said, with the cuff issue. Then if you have a psychometric instrument that's almost the same as in a laboratory measurement, there we speak of, instead of calibration, we speak of reliability and validity. So an anxiety questionnaire or anxiety scale or a depression scale or a quality of life scale, there are hundreds of different scales or instruments. Some call them instruments, measuring or intending to measure some psychometric domains related with the health. So also these instruments should be measuring correctly, and we should make sure that they are reliable and valid. They have been tested before. As it is important in the early phase in the selection phase, in the allocation phase, it is also important at the measurement level to have blinding. If I'm the one who assesses the participants, who makes the measurements, and I know that this patient is the control, the other one is the study patient, I might be confused, I might be biased, and I might make false measurements. Therefore, preferably, also at the measurement level, the participants and the scientists should be blinded. Self-reported and researcher-collected data might also reveal different results. If you administer a questionnaire, if you do blood pressure measurement, any measurement might be different if the participant does it by himself or if it is performed by scientists. If I do the blood pressure measurement in my office with my white coat, it will be a little bit higher as if the patient measures his or her own blood pressure at home. So self-reported, it might be a laboratory measurement or even a questionnaire, and researcher-collected data might also be different. Surely, also memory factor always should be taken into consideration in measurement. What else? Assessment of outcome may differ because of knowledge of exposure, knowledge of the hypothesis, or sometimes also conflict of interest. In the scientific articles, you always see at the end, the authors do not have any conflict of interest. If your work was funded by a drug company and you are studying a medication which is sold by this drug company, you have some conflict of interest. You are biased. We should not trust scientists, or we should be more skeptic for scientific work if it is funded by an interest group. Recall bias, another example for recall bias is this ethyl alcohol exposure or alcohol exposure, alcohol consumption during the pregnancy. If a woman, a mother, has delivered a baby with cleft palate or with some congenital deformities, surely those who have this problem, who have encountered this problem, will remember more whether they consumed some alcohol during the pregnancy or not. Last here is the Hawthorne effect. This is used also in physics, this term, and it is beautiful and fascinating physical encounter, physical issue. You should maybe Google it and read more about it, what it means in physics. But we observe this also in medicine. If somebody knows that he is observed, his behaviors are changing. If you know that somebody is staring at you, you will behave different than if you would be alone. So we include people in our studies, and we tell them that we are going to observe them, we are going to measure, we are going to follow them up. That will make some difference, isn't it? If there would be no information, that would not be ethical. If you would not tell them that we are following, that we are measuring, we are observing them, and still observe them, that is ethically not acceptable. But although this Hawthorne effect is well known and it exists, we don't have any other option. We have to live with this bias. Before the fourth type of bias in this presentation is the attrition bias, and we have also touched up this issue before a little bit. It was about the incomplete measurement of the outcome data, or whether we are conducting our analysis based on intention to treat, or was it a per protocol analysis. To explain this, we have here this a diagram, an example. But before showing the example, I want to remind you once more what it means. Some of your although you have two, let's say two study arms, one intervention and one control group, your participants might not follow your recommendations. Or you tell the intervention group, take this pill, take this aspirin, let us say, take this painkiller. He might not take it. You, in the control group, you suggest or you order the participant, you ask the participant not to take any medication, and he takes the aspirin, he takes the painkiller. So they will not follow up, they will not follow your study protocol. That's leading to this specific type of bias. Let us see the example. Here we have two groups, two participants allocated into two groups, 100 into the medical management group and 100 into the medical management plus surgery group. So these participants, these 100, in the group A, in the group B, they are expected not to undergo a surgical intervention. And this group, they are expected to take the surgery plus medications. What happens after you allocate them? They decide, some of these surgery group, they say, no, I am not going to take the surgery. I will continue with the pills. And some in the surgery, in the medical management only group, they might decide, and otherwise they might decide, hey, I need the surgery, so I will take the. What happens is that's expected, and that's very pretty much common and usual, and it's normal. But important is how we make the analysis at the end. If I move these who have taken the surgery into the surgery group and analyze them in this group, my outcomes, my measurements might be different. You see here, if you analyze it as intention to treat, that means in the group where they are allocated to, not depending on whatever they have protocol they have followed, then you see here you have a relative risk of 1 compared to a relative risk of 0.5 in the per protocol group. So the relative risk reduction is different also, and the significance is different also. That's why we should always take care of this attrition bias, during the analysis phase, take care of how many people, whether the people have moved from one group to the other group, and always try to make our analysis on an intention to treat basis. Okay, the last and easier to understand bias in this presentation is the reporting bias. And reporting bias is the selective reporting of publications. Unfortunately, even if you have followed all your steps, all your protocols appropriately according to the suggestions, during the reporting of your article, you might encounter some bias, and that's also not low. It is pretty much. You see, there is a study here, journals with impact factors. That means high impact factors. There are journals who have some impact, who are cited more frequently compared to some journals, some scientific publications who do not have impact factors, who publish whatever they find. So those high-ranking journals had 100% increased probability. That means an odds ratio of 1.9, 2 times. increased almost, probability of publishing a statistically significant result compared with journals with no impact factor. So if you submit to a high-ranking journal, they want to see some significant p-values, some significant effects. If it is not significant, they are prone to reject it. Or let us say, from the other perspective, a low ranking journal is more prone to publish a scientific work which has found no significant effect. Other sources of bias, as I said in the beginning of this presentation, they are also important. I did not omit them because they are not important, but this is an issue of the time and also the frequency of these biases in our daily practice. But imprecision, like small sample sizes, diversity, like inadequate dose, unusual populations, or other measures of quality, ethics approval, funding, these all need to be addressed as well. And I suggest you once more to go and look to the catalog of bias website for this purpose.